So everyone, welcome. I think this is our second C-Star lecture of the semester. Normally Sigfus Christensen would be hosting, but instead I'm filling in for today. It's 1:01 p.m. on the eastern coast of the United States, so that means it's C-Star time. I just want to give everyone a heads up about the lecture that we're having on October 3rd, which will be by Peter Turkeltaub from Georgetown University, talking about constrained right hemisphere plasticity and aphasia, which I think should be a very interesting lecture. But today I'm very excited to welcome Deena Schwen Blackett, who is now at the University of Central Florida, and she'll be talking about supporting mental health to enhance aphasia rehabilitation. So please welcome Deena, and go ahead.
Thanks so much, William. You can still hear me okay, yes? All right, cool. Well, thank you everybody for coming in person or online and listening to my talk. I'm a longtime fan of the C-Star series, first-time speaker. So I'm honored and excited to be presenting. To start, I just wanted to briefly cover my disclosures. Some of the work that I'll be discussing today was supported by the Duke Endowment, which is a private foundation, and the NIH, and also the University of Central Florida. So to start, I want to real quick lay the foundation for integrating mental health support into aphasia rehabilitation. And as we all know, aphasia care and healthcare in general has become holistic and more patient-centered over time. And today, most of us operate from a biopsychosocial model of healthcare as characterized by the World Health Organization, the WHO ICF. But prior to the introduction to the WHO ICF, the more predominant model of healthcare was the traditional medical model or deficit-oriented approach. And the WHO the framework before the ICF was the ICIDH, or the International Classification of Impairments, Disabilities, and Handicaps. And the focus of this framework or model was on diagnosis and treating disease, impairments, rather than looking at broader contextual or social participation factors. Disability was really seen within the individual rather than the interaction between the individual and the environment. So over time, this focus of this framework or model, over time, the focus has gone from the impairment or the diagnosis to overall functioning in a more holistic model. And here we see the classic WHO ICF figure at the bottom. And then this WHO ICF framework was then applied to aphasia, right, to make the AFROM by Dr. Ara Kagan and Nina Simmons-Mackey and others, and which was part of the larger effort to create the life participation approach to aphasia. And so, of course, I think there's great value in both, impairment-focused and participation-focused intervention approaches, but there has historically been little attention paid to how we address some of the other contextual factors that greatly impact somebody's outcome and how somebody lives with aphasia. So today I'm going to focus on the personal factors. So that's right part of the AFROM or the bottom right part of the WHO ICF, and really looking at the emotional factors and emotional well-being overall, and how we could potentially better address these factors in our clinical practice as speech-language pathologists. So thankfully, there's been a growing amount of attention being paid to the mental and emotional well-being of people with aphasia. It's definitely becoming more and more a focus in our field, which is great to see. There's a new network of professionals called the Aphasia Psychological Care Network that I think was created in 2023 that has working groups dedicated to enhancing psychological care and support for people with aphasia. So there's growing efforts, dedicated to this part. And so if we think about the mental health of people with aphasia, rates of depression and anxiety in aphasia are high. given that it's the most common cause of aphasia, most of this research has been done in stroke in particular, and we see that rates of depression and anxiety among stroke survivors with aphasia are higher than stroke survivors without aphasia. So for depression, 42 to 62% of people with aphasia are estimated to have depression versus about a third of stroke survivors that don't have aphasia. So we also see a similar kind of increased risk in anxiety, with an estimated 44% of people with aphasia having anxiety versus about 24% without aphasia. And stroke survivors are also at increased risk of suicide. This is quite literally, a matter of life or death for some. And then improved emotional well-being is also professed by people with aphasia and their families to be an area of need and really important to them. So we see this big need to have this support. Sorry, didn't advance those slides. But these needs aren't being met. People with aphasia, they're not getting their emotional needs met, and there's a variety of reasons and sources of this problem, including limited diagnostic tools. So we don't have a lot of valid and reliable tools to detect depression and anxiety, for example. We don't have enough mental health professionals to serve even the general population, let alone, mental health professionals that are trained to communicate with people with aphasia and adapt their practice to this population. Some people with aphasia feel a stigma to, get mental health support, and so they might not seek it out. Though I'd argue this doesn't seem to me to be the biggest barrier for this. And then there's, of course, accessibility issues. So people with aphasia are often burdened with so many other appointments and provider visits. And so the burden of having to add another provider visit to their schedule, increase the cost potentially, that is another source of the problem. But also many SLPs are undertrained and feel undertrained and unprepared to deliver psychosocial mental health support in any way. And we think about counseling as one of our, domains of service delivery, but still many graduate SLP programs don't have a dedicated counseling course, for example, and the pedagogical techniques around training clinicians to be good counselors are just less established and developed in our curriculum. So I think all of these barriers deserve attention, and that improving on the service in this to get this major need met will require a multi-pronged approach. So we can't only focus in one area, but we need to kind of tackle this problem from many different angles. And if we think about the consequences of mental health issues in aphasia, of course, it will impact overall quality of life. But what about language rehabilitation itself? So we see, if you're depressed and anxious much of the time, day-to-day living, it's not as enjoyable, it's not as comfortable, it's harder, more difficult. But how does the emotional psychosocial dysfunction or difficulties affect the language rehabilitation process as well? So my hypothesis is that it will also affect language recovery, but we don't have good, clear data on this. But if we think about the mechanisms by which it may, also affect the language rehab itself, behaviorally, somebody who's depressed or very anxious may not come or feel as motivated to come to speech therapy sessions. So they might not be getting as much. They might miss appointments more often. They might, not follow the home programming that was recommended as much. So behaviorally, could be consequences that result in like worse rehabilitation or language recovery outcomes, but also the neurophysiological consequences that could negatively impact cognition. The depressed and chronically stressed and anxious brain, functions differently than a brain that is not depressed or chronically stressed. There's data to show, that depressed individuals and chronically stressed individuals have reduced attention abilities, reduced memory, and overall cognitive ability. And we see evidence of this in just poorer functional outcomes for people with aphasia who are depressed. But the mechanisms haven't been thoroughly explored. So so all of this is to support the idea that addressing these personal factors or addressing emotional and psychosocial well-being could not only improve psychosocial well-being itself, but also improve language rehabilitation. And so if we look back at the AFROM model and we think about, okay, if we target these personal factors and improve them, that could definitely contribute to better overall quality of life or living with aphasia, making it a bit easier. But I'm curious about this other direction of how does that then impact language recovery? Could that also support better language recovery outcomes and also enhance, overall quality of life? So how might we tackle this problem? As I said earlier, I think there needs to be a multi-pronged approach, but as a speech language pathologist myself, I really want to focus on this last bullet point, which is that SLPs feel unprepared or undertrained in counseling, one of our eight domains of service delivery. And clinicians just feel like they lack tools and resources to support people with aphasia in this way. So what's an SLP to do? And why should we do it beyond the reasons I've already mentioned of, it being within our scope, it being part of our holistic care? And I did want to just share the definition or the description of counseling in the ASHA scope of practice, because I think it's good to keep that in mind, because there's often this hesitancy or worry that we're going outside of our scope when we, support mental health, for example. But the scope of practice says that the role of the SLP in the counseling process includes interactions related to emotional reactions, thoughts, feelings, and behaviors that result from living with the communication disorder. So that's pretty broad. So I want you to kind of keep that in the back of your mind. I think a lot could fall under that definition. But beyond that, I think there are other reasons why SLPs are well positioned to support patients with aphasia in this way and to support psychosocial well-being. And there are evidence-based tools and approaches out there that we can learn and infuse into our rehabilitation, and that I think are complementary to our standard practice. But beyond, just providing holistic care, I think we're well positioned to provide this support also because we see people with aphasia routinely. We're part of their standard of care. If somebody is diagnosed with aphasia or suspected to have aphasia, they're referred to us, whereas a mental health professional is not in that, super standard continuum of care necessarily. So we're a bit more accessible to people with aphasia. We are, of course, the experts in aphasia and how to communicate with somebody with aphasia, and we understand more clearly than non-SLPs potentially how it impacts daily life. And we usually see people with aphasia regularly throughout the week. So if, for example, outpatient setting, we're typically seeing clients 1 to 3 times a week. So we get an intimate picture and familiarity of their day-to-day functioning, relationship dynamics, fluctuations in mood and motivation. And so we have kind of a broader picture than I think others might have that can inform which coping strategies we might recommend or are best suited. Sorry, I need to be better with keeping up with the bullets. Um, the other piece is the awareness of community resources. So um, a mental health professional might not know everything out there that could support a person with aphasia reintegrating into their community and their daily life. But SLPs, we have more awareness of those resources and can, pull those out when we need and to help our patients meet their goals. And this is, there's already a framework for us to be doing more of this work, called the stepped care model of psychological care, proposed by Ian Kneebone in Australia. And so this model suggests that SLPs can provide support at levels 1 and 2. And the levels represent basically the symptoms that somebody has. So the more severe symptoms of depression or anxiety, they go up the levels. And speech language pathologists could provide support at levels 1 and 2. Of course, we want to be sure that the SLP providing that support is trained to do so responsibly, right? But we can figure out a way to train them in these different intervention techniques. And there's also a clinical example of this within our field, but within fluency disorders, they're a little bit further along in, adapting cognitive behavioral therapy for the case of people who stutter, and they have tutorials out there for speech language pathologists. So we could kind of enhance our ability to do this in aphasia as well. So this picture was generated by Copilot when I asked it to create a picture representing the discomfort that SLP might feel when talking about emotions or counseling. I think it's really funny. But SLPs report feeling, as we kind of mentioned earlier, discomfort with counseling. They feel unprepared to support the psychosocial well-being of their patients. And they notice that this interferes, or the emotional, reactivity or symptoms interfere with their ability to, do their planned language rehabilitation. But SLPs really don't receive much direct training, if any, in counseling in graduate school or on the job. So what tools do we currently have to support in this way? Up to this point, counseling education in communication sciences and disorders has been focused primarily on what can be called common factors. And those are factors that are kind of common across different intervention techniques that support, good practice and outcomes. For example, like therapeutic alliance with your clients, unconditional positive regard, things like active listening skills and having empathy. And so these are all, common factors that we might try to teach or reinforce among SLPs, as well as general education is commonly, part of our counseling education, and connecting patients with resources. But there are not many formalized intervention approaches that have been adapted and validated for people with aphasia to help them learn these coping skills. So we have, a decent or a growing, level of education and counseling with the common factors, but less formalized intervention approaches. But research in this area is growing. So Dr. Will Evans and Dr. Eric Meyer in Pittsburgh are working on adapting acceptance and commitment therapy for people with aphasia. Dr. Brooke Ryan and colleagues in Australia have a program, the ASK program. And then Sarah Northcott and colleagues in the UK have solutions-focused brief therapy. So there are things under development, but they're still in kind of the early stages. and I'm going to talk about some of the work that I am doing as well. And then, so if we think about how would we integrate this into our clinical practice? Well, if you are a clinician who's using the life participation approach to aphasia, this isn't too far a jump from what you're already kind of doing. The LPAA, of course, centers holistic care, calls upon SLPs to address not just the language of impairment, but the environment, personal factors, including the emotions and attitudes and participation in life situations. And rehabilitation outcome is not measured by language ability or recovery. It's measured by quality of life and participation. And it explicitly says that intervention targets can be personal and environmental factors. So those other parts of the AFROM. And so I am a proponent of, figuring out ways to integrate cognitive behavioral therapy techniques into our practice as SLPs. I think that we can train SLPs to employ CBT approaches alongside language-focused intervention that could serve as an adjuvant to traditional speech therapy. And so other formalized approaches that we might think about within this CBT umbrella could be, behavioral activation, which I'll talk more about soon, relaxation, training or mindfulness, cognitive reframing, though cognitive reframing has a bit more of a demand on language, right? If you're identifying unhelpful or negative thoughts, challenging them and reframing them, that requires a bit more of a baseline language ability. And then just general psychoeducation, right? A lot of times SLPs aren't even, setting time aside to educate clients about the psychological impacts of aphasia and hearing, kind of setting the stage to invite that information from clients and to educate about symptoms of depression, anxiety, and so forth. I put an asterisk there because it's not necessarily its own intervention. It's kind of a supportive intervention that's included in a lot of these other techniques, but still very important. So I wanted to mention it. Okay, so now I'm going to talk about the actual research and work that I've been doing along these lines now that I've laid the foundation. I'm going to talk about two projects. One is SLP administered behavioral activation, and two is another project that I'm working on with folks at Medical University of South Carolina to integrate CBT principles into stroke telerehabilitation. So for those of you who aren't familiar with behavioral activation, it's a cognitive behavioral therapy technique for primarily depression, though there are some studies out there that are exploring whether it could also treat anxiety. And there are some, there's early evidence suggests that yes, it can. But I think this could be an especially promising intervention approach in aphasia because it is shown to be so effective. It's one of the more effective psychological interventions out there. And it's been shown to be effective in a range of populations, including those with chronic health conditions. It's been done in breast cancer, PTSD, older adults, and including aphasia, actually. The group in the UK, Shirley Thomas's group, has done some great work looking at behavioral activation in aphasia delivered by mental health professionals. Not necessarily SLPs, but good segue into the next bullet, which is that behavioral activation has been shown to be effective when administered by non-mental health professionals. So this is a relatively simple type of intervention that we could learn and integrate. It's also very well aligned with the life participation approach to aphasia because the essence of behavioral activation is increasing engagement or participation in activities that one finds enjoyable and important. So that's also kind of the goal of LPAA, right? But less of an explicit kind of tying to somebody's individual values, and less, it's a bit more structured way to target and increase participation in those activities. And like I mentioned, there is data to support efficacy of behavioral activation with people with aphasia, but as far as I know, I haven't seen it, data being done when it's administered by a speech language pathologist, and really seen much work integrating it into like a standard clinical type of setting. So what is behavioral activation? What does it look like? I kind of already mentioned this, but beyond that broad kind of definition, what's required is that you track your daily activities. So you have to understand, how are you spending your time? What activities are you currently doing? How much do you enjoy those activities? How important do you think those activities are? So gaining an awareness of how you're spending your time and tying it to your mood. So you also track your mood in addition to the activities, and make that connection between the behavior and your feelings. And then you also are required to generate and schedule values-based activities. So in these 5 life areas, personal relationships, mind, body, and spirit, education and career, recreation and interests, and daily responsibilities. These are the 5 life areas that you go through with somebody, and you identify values that they have in each of these areas. And then you select and identify activities that are in line with those values. And once you have a good list of activities that, are well aligned with your patient's values, then you can start scheduling them into their daily life. And the whole point, right, is that people will often not feel motivated to do those activities because they're not feeling good. They're feeling depressed, for example, or anxious. But really convincing and justifying, or kind of getting the buy-in from your patient about, you know, once you do activate the behavior, once you do the behavior, you will feel better. So they have to have that understanding and of the connection between doing the thing and then they feel better, because they're depressed. They're not going to necessarily feel motivated and excited to do those things. So for this pilot study, this was while I was a postdoc at MUSC, and I was working with Dr. Lisa McTague, who's a clinical psychologist, and a student of mine, Deena Schwen. And the goal of this pilot was to examine the preliminary benefit, the feasibility, and acceptability of an SLP delivered intervention for people with aphasia, employing mostly behavioral activation, but we added on just general psychoeducation, sleep hygiene education, and relaxation training. But behavioral activation was the primary ingredient, and was the primary ingredient carried over from session to session. So we did a mixed methods study with just a single group with a pre-post design, and the intervention was administered by me, certified SLP with guidance from a clinical psychologist, and that was Dr. McTague. And we did 5 intervention sessions, each one once a week for an hour each session. And we recruited 11 people with aphasia. 2 were female, 8 were male, so majority male sample, and majority white sample, and mostly mild to moderate aphasia. You can see the WOB classifications of our sample here. So a lot of them had anomic aphasia. So it was skewed toward more mild or moderate. These were our inclusion-exclusion criteria. We really just focused on stroke participants, and we included people who are at least 1 month post-stroke, but I think the most acute patient was 4 months post. So most people were in the chronic stages. And we did have to exclude people with severe auditory comprehension deficits, given that we were using patient-reported outcomes that were still language-based, and a lot of this intervention required kind of more conversational discourse to some extent. So here are the demographics of our sample. You can see the WAB-AQ mostly higher up, mostly months post-stroke, 4 months to 139 months, and it was relatively educated group. We delivered the cognitive assessment for stroke patients, which is aphasia friendly, if you will, for a cognitive assessment. And so they had, I think, relatively spared cognition overall, but definitely worth exploring more, the role of cognition. So participants attended 8 sessions total. They came in for a baseline session where we did a lot of psychosocial measurement, and we did the cognitive assessment and language. Then they came in for 5 intervention sessions, and then a post-intervention session where we did the same psychosocial measurement after the 5 sessions, and also did a post-intervention interview, semi-structured interview. And then we had a 1 month break, so we followed up with them 1 month later and did the same quantitative and a little bit of qualitative follow-up. But in between those two sessions, we did kind of check in with participants weekly via calls or emails, just to see how they were doing, to check in about the activities we had identified or planned, to see if they needed to problem solve or talk through anything. But those interactions were relatively brief. The testing sessions in red were also conducted by a separate person. So Deena Schwen, who you saw on the previous slide, administered those without me being in the room. So since I was the one doing the intervention. Our primary outcome measure was the Hospital Anxiety and Depression Scale, or the HADS, which has been used with people with aphasia before, but truly, I don't love it. It still, requires language comprehension and a decent amount. The response options switch for each question. So in my current work, I've shifted a bit from the HADS, but it was also appealing to use because it's one of the outcome measures, tailored to the stepped care model. And we did use supportive communication techniques when delivering the HADS, but important to keep that in mind. And then we also did secondary outcome measures, a whole list of those, just to look at other aspects of psychosocial well-being beyond symptoms of anxiety and depression. So the results, we saw that on the HADS depression scores, there was a significant decline in depression symptoms from pre to post treatment. These were t-tests, and from pre to follow-up, that was no longer significant. So there was kind of it wasn't maintained longer term. And for anxiety, we did not see significant reductions in anxiety symptoms. And if we look at the individual data, there is variability there, right? So that was on average, we saw significant reduction in depression, but there was some individual differences. And then for anxiety, we see even more variability. And you see that one participant who shot up from pre to post in anxiety symptoms, and I'm happy to talk more about that if there's time at the end. But looking at the statistical tests, even if I excluded that person from the anxiety test, it still was not statistically significant. But we do see, fair effect sizes on the right here. So I was honestly surprised to see a significant difference with just 11 people after just 5 sessions. Again, this is not a controlled pilot, so we can't say for sure what's going on, but some preliminary data to support a benefit. This is results from pre-treatment to the 1-month follow-up. Though we see at the top that depression was no longer significant, and anxiety. However, once we did remove an outlier from the anxiety pool, there was a statistically significant difference from pre to 1-month follow-up. There were some other significant changes that we didn't necessarily expect. The SAQUL communication score, the communication quality of life score, was significantly different from pre to 1-month follow-up. And the DVAMs, just the one item, the sad, happy item, when excluding an outlier, was statistically significant in a reduction. But again, very small sample, we need more data. If we're really, the main goal of this project was to look at feasibility, and 100% of participants completed the intervention and attended all the sessions. We were able to administer all the assessments and intervention components that we had planned. And 100% of participants, when we asked if they'd recommend this intervention to other people with aphasia, they all said yes. And when asked follow-up questions about whether they think this type of an intervention should be included in just like a traditional speech therapy session, many said that they think it should be. And I'll elaborate on some of the qualitative findings too. So overall, there's some signs of a preliminary benefit for depression symptoms that was not maintained. So we need to consider dosage and what other factors might lead to better maintenance, and no significant change in anxiety symptoms. And then qualitative results. So when looking at the post-treatment interviews, generally the feedback was positive. Behavioral activation and relaxation training were considered to be the most helpful intervention components. We asked people which parts they preferred among behavioral activation, the relaxation training, the psychoeducation, and the sleep hygiene education, and they really liked the behavioral activation and the relaxation training the most. They liked sleep hygiene the least. Happy to chat more about that too. And then we also asked, when in your recovery would you think this type of support or intervention would be the most helpful? And views varied on this question. Some folks felt like in the more chronic stages, subacute to chronic stages, they feel like it would be best because, the initial shock has worn off and they're starting to realize, this is something that I'm going to have to live with longer term. But others felt like they would have liked this type of emotional support right after having their stroke. They also pretty commonly had the belief that although they do think this type of work would be helpful in traditional speech therapy sessions, they didn't want it to take over, right? They still wanted to make sure there was enough time to focus on the communication ability and rehabilitating it. And so when asked, if you had to divvy up a session with some dedicated to like these psychosocial supports and coping skills versus language focused intervention, how would you split it up? Some people said 50-50, but most often it was something like 75 to 80% communication language focused, rehab, and maybe 15 to 20 or 20 to 25% psychosocial coping skills. The also thing to note is that the majority of participants in that sample did not have experience with mental health treatment before, doing the study. but they were receptive to it. Now, I'm sure that there's definitely some selection bias going on here, right? That if they chose to be in this study, then they're obviously probably receptive to it. But I do feel, based on my just personal interactions and conversations with people with aphasia, that there is something about seeing an SLP versus a mental health professional. There seems to be some additional stigma attached to seeing a mental health professional and seeking one out. So that was interesting. Other key takeaways are that, early evidence suggests that SLP administered intervention and behavioral activation in particular is feasible, it's acceptable to people with aphasia. We did see some preliminary benefit in reducing depression, but there was individual variability. Throughout this study, we also, we did suicide risk screening, and we found that, we found that more than one person was revealing, suicidal ideation. And so we'd follow up with participants throughout the study. And it became clear when we ask about these issues, they tell us, they tell us this is a problem, but oftentimes in our clinical practice, we don't make the space for that or even ask. But that is really important, right? Like we could get them the help they need and potentially keep them from committing suicide. And it's clear that having the support of clinical psychologists in this work is really important. And even though we might be delivering some of these interventions, having the support of a clinical psychologist or another mental health professional will be important going forward. So real quick, I want to touch on the other project that is really exciting. This has been spearheaded by Dr. Woodbury at the Medical University of South Carolina. And this is the project funded by the Duke Endowment. And she has designed an amazing study. I'm helping as a co-PI as well as Dr. Lisa McTague, the clinical psychologist I've already mentioned. And the aims of this study are to examine the effect of integrated cognitive behavioral therapy principles into telerehabilitation therapy on emotional health. So we're seeing stroke survivors with and without aphasia. If they don't have aphasia, they see OT. If they have aphasia and they want speech, they see me, speech therapist. And so it's a randomized trial, and that's the goal, is to kind of see not just as a standalone type of intervention, but how can we integrate this into a rehab protocol? And then the other aim of the study is to test the feasibility and the initial effect of post-rehabilitation community-based emotional wellness groups. So it's clear, that there's maybe not as much maintenance, or maybe for certain people, the maintenance will be difficult. But having a model for integrating some of this carryover into a community-based group could be really exciting. Oh my God, I'm sorry, everybody. Keep forgetting to advance the bullets. So aim one, like I said, the randomized control trial is underway currently. Folks are randomized into a CBT integrated speech or OT versus just regular speech and OT plus stroke education delivered all by telehealth. And we're measuring emotional well-being outcomes before and after intervention. And then the second aim, we haven't started on yet, but the idea is that participants will join an 8-session virtual group with about 8 to 10 stroke survivors, where we will kind of carry over the CBT strategies after the one-on-one interventions. And again, we will be measuring emotional well-being before and after those. And for this, we're partnering with Stroke Onward as well. Wonderful organization, really dedicated to supporting emotional well-being. And so they are going to collaborate with us on developing the materials and the curriculum for these virtual support groups. So overall discussion, of course, we need more research on the efficacy of CBT techniques when delivered by speech language pathologists for people with aphasia. And we need more research on how to integrate that into our speech therapy sessions. But this type of work, like developing an effective and formalized intervention approach, could have the potential to help SLPs feel better equipped to support psychosocial well-being of their patients. So I think part of the root of why SLPs have discomfort or don't feel prepared is because we're taught more of these common factors type of skills rather than like a targeted formalized intervention approach that we know how it works and we know how to implement. And then my overall hypothesis really is that addressing psychosocial functioning could improve quality of life by improving mood itself, but also potentially by improving language treatment outcomes. But of course, we need more research to test this hypothesis. But if we can, alleviate some of the neurophysiological effects and behavioral effects of depression, anxiety, and chronic stress, that could create better conditions to conduct language rehabilitation. And, there's a growing literature, right, that supports the importance of domain general cognitive abilities, non-linguistic cognitive abilities in aphasia treatment outcomes. So this could be another method by which we target those cognitive abilities. And I think this is important because it helps our endeavors to more personalized and keep our work patient-centered and holistic. So with that, I'd like to thank you for coming and listening, and thank you to all the participants and their care partners who facilitated the participation. Also, many thanks to Dr. Woodbury and Dr. McTagg and Dr. Wilmsquetter for all of their support in this work, and all the other mentors and collaborators, and all the students who have helped me with this work as well. And I look forward to hearing questions. Thank you. I can't hear anything, but maybe I shouldn't be. Should I wait?
Yeah. Yes. Sorry. Yes. The microphone was muted, but there was great applause in the room for your talk. We appreciate that.
Thank you.
So with that said, are there any questions in the room for Dr. Blackett? We've got one from Zainab.
Hi, Deena. Great talk. Thank you. So just a quick question. I wonder if you did measure the anxiety in a follow-up session stage. So do you think there was like an improvement in their language impairment? So maybe there was like an improvement in their confidence because of improvement in their language impairment, so it can affect their anxiety. So did you consider that?
It's a good question. Yeah, because we did see that significant difference when we excluded the outlier at the follow-up stage. And we did see a significant change in communication quality of life on the SAQUAL from pre to 1 month follow-up. So it is possible that significant difference at the 1 month follow-up stage was related to just improved communication overall. And we didn't really control for that or measure communication language ability pre-post. We just did it at the baseline so that is definitely the next question, is how is language improving alongside some of these social, psychosocial factors? It's a great question.
There's one from Chris.
Yeah, I enjoyed the talk. So one quick question. You told us that on average, the patients felt they had kind of like this balance of about 75% language skills, 25% social coping skills. How about your own subjective opinion? As someone who you see a lot of patients here at speech language pathologists, did you also feel like that kind of split felt like you kind of a good way to, have a good rapport with people, be able to find out where they're at, decide maybe if you wanted to have a specialist involved, or would you put a similar number?
Great question. Thank you. Yeah, I actually do kind of agree with the 75-25 split from a clinician's perspective. That, if I think of like an hour-long treatment session, if I spend 15 minutes at the beginning checking in, doing some of these more psychosocial types of interventions, and then the remainder 45 minutes is, language focused rehab, I would feel like I am targeting and supporting both in kind of in tandem without sacrificing time to really work on rehabilitation. So personally, I think that would be a great fit. But of course, I'm biased, like I really value and prioritize psychosocial functioning. But we definitely should interview more SLPs and get more SLP input on, what, if they think that's a feasible option, if they think that would be beneficial.
Other questions from the room about Deena's talk? We do have some from the chat. And so I think I'm just going to try to see if I can actually get those who asked their questions to unmute. So I'm going to see if I can find. We have one from Kristen Emerzale. I'm going to just see if I can get you to unmute. Kristen, if you want to ask the question yourself.
Sure, I'm still here. Hi, thanks for the talk. It was interesting. I was curious when you were talking about the 1 month, I think I understood you correctly. At 1 month post the maintenance phase, the gains weren't maintained. Was that correct?
Yes.
So I was curious how that compared to behavioral activation with people without aphasia. And maybe you could speak to, maybe you have to hypothesize, but why you think those gains weren't maintained.
That's a great question. And I don't know off the top of my head, at what level or how, like typically how long the benefits of behavioral activation are maintained in non-aphasia populations. But behavioral activation treatment is typically delivered at a higher dose than what I did for this study, which was just 5 sessions, 1 hour each. And so I have a feeling, right, that with more sessions with a higher dosage, maintenance would be better. But that's a great question and thing to look into, that we need to compare with what's the norm, right, in people without aphasia.
Great. And then we had another question. I didn't know if you wanted to respond to that at all, Kristen. Okay, perhaps not. We had another question from a random participant. I didn't recognize the name Dirk Denouden. I don't know. So I'm going to ask Dirk if you're there to unmute and if you would like to ask your question live.
Ah, the banter. Don't I miss it? Hi, Deena. Thank you so much that's a great talk. I really love the topic. I was wondering if you can talk about or know of precedents where this type of approach has been used deliberately while also offering the type of activities that may be engaging or enjoyable, right? So not only asking people to seek these out or to reflect on them, but also at the same time offering an intervention like that. Are there precedents for that? And I'm of course thinking of like things like arts-based interventions like choirs or drama or other interventions maybe.
So are you asking like within a same session, like identifying?
Yeah, right. Yeah. So to offer an activity like that and then to use the BA approach to reflect on it, right? And to, yeah.
No, I don't know of any work that's done that, but that's exactly what I would imagine would be such a great complement within a speech therapy session, right? Is to identify these values and activities, and then in the other parts of the session, potentially target the communication acts related to that activity, if it's, directly related to the types of language we would be targeting. So I think that would be a great, avenue to explore further. A good idea.
Great. So I think that was most of the questions. I actually had one as well, which was just concerning if you know much about the baseline usage of therapy by patients, people with aphasia, just in general, like how often do they seek treatment from mental health professionals? Do we know much about that baseline, and how would that potentially interact with whatever interventions that you may be suggesting that SLPs do?
Yes, good question. Unfortunately, we do not have good data on this, but there are some who estimate that less than 1% of people with aphasia get mental health services, direct mental health services. I haven't found like clear good data to support that claim. I'm not really sure where it comes from exactly, but we need to know that, right? We need to know that as a baseline. So it's definitely an area of research I support.
Great. Okay, so I think that unless there are other questions in the audience, I think that we'll just have to thank our speaker again and invite you all to come to the next C-STAR lecture.
Thank you all. I appreciate it. Thanks for the applause. I can see your hands moving, but I canceled it now. Bye.